We're talking this afternoon with Prof David Newby, British Heart Foundation, Duke of Edinburgh, Professor of Cardiology at the University of Edinburgh.
I'd like to ask you about the Scott Hart 5-year data, which was published in the New England Journal last year. Could you please recap those findings for us today? That would be really helpful.
So it's a study really looking at rapid access chest pain clinics in the UK. So patients referred by the GP to a cardiologist for assessment of angina. And what we did is we took about just over 4,000 patients across Scotland, 12 centres, and we randomised them to either having a CT scan on top of standard of care or just standard of care alone. And standard of care could be anything and included treadmill testing, use of nuclear perfusion imaging, whatever the clinician wanted. And in fact, around 10% were already referred for invasive angiography. So it was an all-comers trial. And what we found was that the CT scanning changed the diagnosis in 1 in 4 patients, the investigations in 1 in 6, and actually the treatments in 1 in 4. And we followed them for 5 years using routinely collected healthcare data. And after a median of 4.8 years, we found that it nearly halved the rates of fatal and non-fatal MI. It was a 0.59 relative risk reduction, highly statistically significant.
I mean, that really is a remarkable reduction in non-fatal MI. How do you think that the Scott Hart trial can explain that?
The primary outcome of our study was actually the diagnostic certainty, which the CT scan clearly doubled the diagnostic certainty for the clinician. And of course, when you change the diagnosis, you do lots of different things. As I've said, you change treatments and you change tests. And if you look at how much treatments changed around statins and aspirin certainly increased significantly in the CT arm, is much higher than in the standard of care arm. It also changed what tests they had. So initially in the first year, there was an excess of angiography and an excess of revascularization in the CT arm. But after a year, interestingly, that reversed. So after a year, if you were in the CT arm, you're less likely to need a subsequent angiogram, less likely to need revascularization. That's because, of course, the CT scan found the right person, it gave them the right tests and gave them the right treatment straight up. And that's why I think we saw that difference, because the treatments changed. Now, some people have said, well, the treatments didn't change that much, so statin use was 10% higher. But that hides the fact that you've changed it. So some people will stop statins and some will start. So overall 10% difference, but actually it's a much bigger difference in terms of starting people on statins and treatments like that. And of course the patient is not inert in all of this. So people who've had a CT scan are more likely perhaps to change their lifestyle, to stop smoking, to exercise, diet more. So I think all of these factors, changing revascularization, changing secondary prevention, changing lifestyle, all came together to reduce the heart rate. One of the things that we're currently doing is trying to get into the primary care data to see if we could see a difference in cholesterol levels, see if we could see a difference in blood pressures, see if we can see a difference in quit rates. I think one of the interesting findings of Scott Hart was also that most of the heart attacks that subsequently happened in people who had non-obstructive disease. So these people did not have severe stenoses in their coronaries at baseline when we first met them. Obviously, the statins and these treatments prevent that disease progressing. But ultimately, the people that went on to have a heart attack who had a CT, more than half of them had non-obstructive disease. So actually, what the Scott Hart data shows that CT is great at picking up coronary atheroma. It does help the diagnosis, I'm not saying it doesn't, but actually it's finding atheroma in your coronary arteries which seems to be most important.
Could you give us a brief insight as to what Scott Hart 2 is going to be adding above Scott Hart and what the sort of primary and secondary outcome points will be within that?
So if you actually look at the relative risk reduction in the groups that we saw in Scott Hart, actually the biggest risk reduction was in patients who didn't have angina, which is interesting. So it's the non-anginal group and they had a hazard ratio of 0.46. And I think it comes back to my earlier point, which is what CT scanning is doing is telling you you've got atheroma and therefore act on it. So what Scott Hart 2 is going to do is to take people without symptoms who are middle-aged and have at least one cardiovascular risk factor and randomise them to a standard risk score-based approach, QRIS2 or in Scotland the assigned score, work out what their 10-year risk is and then they get their statin, versus the other half of the trial group, we will get a CT scan. And then if we find atheroma, we will treat them not only with statins, but also with aspirin. Obviously, both groups will get lifestyle advice, and that will be a perfect opportunity to test whether lifestyle advice changes according to a CT scan. And obviously, we will also find people with obstructive disease who apparently don't have symptoms, so subclinical disease, and seeing whether treating that might also be beneficial. So it's really a head-to-head comparison in a primary prevention setting, arguably, of a risk score versus screening for the disease with CT scanning.